each of us here plays a really vital role in the chain of survival for the trauma patient. One of the challenges is that there are so many independent links that each has a bearing on the outcome. So whilst most of this audience are responsible and are involved in the prevention of the trauma happening in the first instance, I guess my major role is when that trauma does occur and that patient is brought in via the ambulance service to our hospitals. And one of the problems that we have had over the years is that we weren't able to see exactly what was going on for these patients. Their care was provided through various hospitals throughout and continues to be provided through various hospitals throughout the country. And that therefore creates challenges in terms of providing a streamlined packaged level of care of an excellent standard when a patient outstrips the smaller hospitals' ability to provide that response to their injuries. So at the moment in Ireland, we have 27 receiving trauma hospitals. There are 2 neurosurgical centres, Beaumont and Cork. There's a separate centre for pelvic trauma. There's a separate centre for spinal trauma. There's a separate burns centre. There are separate cardiothoracic centres. And it is therefore very challenging to provide the all-encompassing holistic package of care that is required for the severely injured patient in that sort of a setup. And we are working at modifying that setup and creating trauma networks. And that is a meeting that I was at this morning at Dr. Stevens, whereby we were looking at creating 2 trauma networks for Ireland that would be able to deliver a streamlined package of care. So rather than bringing the patient to the nearest hospital, you were bringing the patient to the right hospital in the right time with the appropriate level of care available to the patient when they got there. Because a trauma system is about injury prevention, obviously, but it's also about pre-hospital care. It's about making sure that when the patient does get to the hospital, that the acute care facilities are of a standard that can optimize that patient's return to normal life. It's also about rehabilitation and post-hospital care. And it's vital then that we have some method of measuring how that system is performing for our most injured patients. This guy, Edward Deming, or William Edwards Deming, was famous for his revolutionary ideas when it came to Toyota manufacturing. But his statistics have pervaded across many other sections of society, and they're very endearing and very important to us in the area of major trauma audit, because you can't manage what you don't measure. And up until recently, we weren't able to measure what was going on for our trauma patients. Trauma audit is like having a dashboard in your car or having a dashboard in your space shuttle. It allows you to see what the various process measures are that contribute to the outcomes and see how they're performing, and if they're not performing adequately, to intervene and put in place systems whereby they can be compensated. And around the globe, many countries have invested in major trauma audit. In Tanzania, I spoke to a researcher last week, in fact, who was establishing trauma audit in Tanzania. And likewise, we have done so here. We're up and about now in Ireland since over the last 2 years through the offices of the National Office of Clinical Audit. We now, I'm glad to say, have major trauma audit up and running. But throughout the world, this is a very real, a very important aspect of the trauma system, audit of major trauma. And why is audit so important? Well, it's important because we need to be able to benchmark where we are against where other people are, so that that will drive on our quality improvement and our quality assurance. We need to be able to put in place best practice and see that best practice is in fact in place. We need to be able to monitor equity of access, so that that patient who has that car crash up in Letterkenny has the same access to care as that patient who has a car crash on the M50. And we need to be able to monitor that. We need to be able to provide feedback to providers so that we can tell them when they're doing a good job, and we can tell them what aspects of their system needs to be modified so that they can do an even better job. We need to stimulate competition. I need to be in competition with the Dublin hospitals. I want to see that my outcomes in Cork are better than the Dublin hospitals because I'm a proud Cork guy, proud Cork man, and we need to make those, we need to engender that sense of competition so we drive on quality improvement and quality assurance. What matters to clinicians isn't so much the binary of deaths or people who die versus people who don't die. What matters is who dies that shouldn't have died. Okay, because we all know that there are catastrophic traumas that happen out there that with the best hospital systems in the world, you will never be able to save that patient. But what's more concerning to us is those where we may have saved the patient and where we didn't. And so we need to be able to risk adjust those patients who suffer major trauma so we can compare apples with apples, that we can compare patients of similar age, similar injury demographic, similar comorbidities against those in other jurisdictions who sustain the same level of injury, who've got the same features before this accident, so that we can see how our system compares more accurately. That means a lot more to us, actually, than deaths per se. Audit is particularly important in trauma, and the reason for that is, number one, because trauma costs a lot to provide excellent trauma care, and we want to be making sure that we're getting value for money in terms of the trauma care that we're providing. But it also costs a fortune if you have patients who do badly or do much worse than they should do, because there's an ongoing societal cost to that family, to that patient, and to the system as a whole in terms of managing that patient for the next 40, 50, 60 years of their lives. Luckily, when we set about setting up Major Trauma Audit, we were able to look to our English and UK colleagues, and we were able to pull an off-the-shelf model, essentially, of major trauma audit that was established and well established over the last 20 years in the UK, and that's TARN, Trauma Audit and Research Network. It's associated with the University of Manchester. It's the largest European trauma registry, and it's been up and going since 1990. It's self-funded through hospital membership fees. So each of our hospitals in Ireland pays a license fee through NOCA. So NOCA, the National Office for Clinical Audit, provide the arrangements whereby license fees are paid for the hospitals that are providing data. And I'm glad to say all our major trauma hospitals, or all our hospitals that are receiving trauma, are now contributing their data. The beauty of TARN is that it's clinically led, it's academic, and it's independent. Okay? The statistics, the numbers don't lie. There's no airbrushing these numbers. They are what they are. And it's well established in England, Wales, Ireland now, Denmark and Switzerland. Now, TARN doesn't collect people who go over on their ankle, who pull their back. TARN collects the pointy end of trauma. It's those patients that are admitted to our hospitals for 3 days or more. It's those patients who come into our hospital but are quickly transferred on for ongoing care. It's those patients that require ICU, okay, or those patients who have died once they got to the hospital, not those who have died at the side of the street or out on our roads. Okay, it captures a very specific pointy end of the trauma spectrum. Okay. What it is doing then is it's capturing all the data that relates to the outcomes, all the process data. So it captures their physiology, their blood pressure, their level of consciousness. It captures how quickly they were seen by a trauma team, who were in the trauma team, who led the trauma team, was it led by a consultant? It captures how quickly they got onto the CT scanner to have their diagnoses made, and how quickly they got to theatre, how long they stayed in ICU, how long they stayed in hospital, their access to rehabilitation, whether they survived or not. Okay? And that is what TARN is all about. That is what major trauma is all about. So it's about capturing the process measures that contribute to the outcomes. And through NOCA, we are able to feed back to the individual hospitals their performance. So these are the various things that I've just outlined that are collected through TARN. And the beauty as well is that there are best practice guidelines for various trauma injuries, for example, head injury, that we can compare our performance in Ireland with the best practice based on what we're finding in the audit. As I said, there's no point comparing a 20-year-old who sustains major trauma with an 80-year-old who is on various medications for their heart failure, various medications to thin their blood. There's no point making that comparison. Okay? It's an unfair comparison. So we need to be able to risk adjust who we are comparing in terms of injury profile and what other comorbid diseases they have, so that we can provide clinicians and care providers with realistic information and information that can influence how they manage their hospitals and how they manage the provision of care. So we now have 7,000 patients on the TARN registry for Ireland, and this is what it shows to date. We've been collecting data now since 2014, and various hospitals are at various stages of putting in their data, okay? But road traffic accidents are a significant cause of major trauma audit or major trauma in Ireland, but actually falls from less than 2 meters constitute an unexpected for us, very significant burden and volume of work. And that's true for the UK as well. The patient demographics, we all think that major trauma is a young man's disease. It's not. The median age for females is 66 years of age, and the median age for males is 48. Now, if you were to take out the cohort that are related to traffic and road trauma, that may well be a younger age group. But for major trauma care provision, it is not just the disease of the young adult who's crazy on the roads. It's you and I as well. It's this audience who has a fall from a ladder, who gets knocked by a car out on the road there as you leave this conference. Trauma's not necessarily a 9-to-5 job. It is not in any way a 9-to-5 job, and therein lies a challenge for the provision of good trauma care. They tend to come out of hours at weekends, and so providing consultants and hospital staff so as that they're there at that time is challenging. And it can't be done across 28 centres to a level that is adequate to provide the optimal care for that patient. So this is how we're doing. We're doing okay in terms of our survivors in Ireland, but we could do a lot better, okay? So at the moment, when you compare our number of survivors to those in the UK, and when we're comparing it to the UK, we're comparing it to the UK over the last 20 years, okay? So they've seen a massive improvement since 2012 in the UK, and I'll talk to that in a minute. But when you compare our performance in Ireland to that of the UK over the last 20 years, we have 1.93 excess survivors per 100 patient presentations to our hospitals with major trauma, okay? 1.93 excess survivors, okay? 1.93 unexpected survivors, okay? And this is the caterpillar plot, and this allows me to see where my hospital sits compared with all the other hospitals that contribute data to major trauma audit. And as I said, competition is very important, okay? And here is where Cork sits. You can see the red dot, okay? It's spot on in the middle, okay? But I want Cork to come out towards, I want Cork to improve, and I want to see it coming up towards the outside level of that graph, along with the best providers that are contributing data, okay? That sense of competition is vital, okay? And that's the same data presented on a funnel plot. So obviously, if we're collecting this data, there has to be a governance structure around how we do that. And NOCA provides this governance structure. The National Office of Clinical Audit has now got a number of discrete audits feeding into it. It's got major trauma audit as the first out of the traps, really, but it's also got a mortality audit for hospitals, an ICU audit, a surgical mortality audit, an orthopedic audit, and various audit streams. And each of those audit streams has got a governance system around it. So there are people looking at the data as it comes through, stakeholders who understand what is being described. So we've got stakeholders from the various specialties that contribute to major trauma care, and we also have patient representatives. And we engage then with the hospitals when we find outlying performance. So if we've got unexpected survivors or unexpected deaths, we speak to the hospitals and we support them in examining the cases to ensure that that is in fact what is going on, that it's not an aberration in the data, that it's not a problem with the data, that it's not a problem with the reporting, that what we're seeing in the data is real, and then if it is real, that we are putting in place structures so that we can mitigate whatever it is that's causing them to have the outcomes that they're seeing. This is a really key slide, okay, and this is what I think needs to drive the reformation of trauma care provision in Ireland. So since 2012, since they changed how they deliver trauma care in the UK, whereby they brought patients who were within 45 minutes of a major trauma centre direct to a major trauma centre, bypassing smaller hospitals. In other words, they were bringing the patient to the right hospital rather than the nearest hospital. They have seen an improvement in the odds of survival of 55%. That's remarkable. That's breathtaking. And that has really stimulated us in Ireland. We've been charged with setting up a strategic advisory group to advise the Minister for Health, whoever that will be, on how we will provide major trauma going forward, major trauma care in Ireland going forward. Okay, but that is a game changer. How they've done that in the UK is remarkable. It was done in the US, in Australasia, 15 years ago. It's only now that it's happened in this neck of the woods. But there is a huge opportunity here for us to save lives. Okay? And as I said, how they did it was bringing patients to the right hospital rather than the nearest hospital. And they also incentivized best practice. So they provided extra remuneration to those hospitals that were seeing the major trauma, and they provide those hospitals that weren't getting the major trauma but were getting trauma to stabilize to then move on to the major trauma center. They were incentivizing those hospitals to get those patients on to the next level of care quickly and incentivizing them for best practice targets while they were at that hospital. So, I'm within time, I'm glad to say. What I've described, I hope, is the fundamental importance of major trauma audit. It's great that we now have a system whereby we can see the impact of the technologies that you are describing here this morning, that we are describing here this morning, and see how they impact on mortality outcomes. Okay, so we now have a way, a very robust way of seeing in a risk-adjusted manner what our outcomes are, what the outcomes are of the various interventions that we do to our trauma system, that we do to the provision of major trauma care on this island in Ireland. So Trauma Audit, it's a vital quality assurance and quality improvement tool. I would advocate for making major trauma audit mandatory. It's not at the moment. We're doing it on the goodwill of the hospitals. The hospitals are providing the data collectors and they're finding it within their budgets to do that because they recognize the importance of it. But I think this is something that really does need to be mandatory, and in so doing, that it's sustainable and that it's resourced so that we can get the most out of the data that we generate.